Welcome to Pathology Central Key Concepts. The topic of this video is cell injury and necrosis. There is a separate video on apoptosis, but since cellular injury can merge imperceptibly with necrosis, I thought it would be best to cover these two topics in this video. I'm going to discuss the role of cell injury and disease, the processes involved in cell injury, the pathophysiology of necrosis, and I'll finish up by comparing and contrasting the different morphologic types of necrosis. So, think about the happy, healthy cell, which we see sitting here. It has some sort of physiologic or pathologic stress. So physiologic stress could be pregnancy. Pathologic stress could be increased blood pressure, putting stress on the heart. And in response to these stresses, the cell is going to first try to adapt. This will lead it to a new steady state with preserved viability and function. So for example, in the instance of pregnancy, perhaps additional genes are upregulated, more proteins are made to deal with this additional stress. In the case of hypertension, the cardiac myocytes might hypertrophy, thereby giving it the ability to press against that increased pressure. However, if this adaptation is exceeded or the external stress is too profound, then we will move on to cell injury. Now, there are two types of cell injury. There's reversible cell injury, in which the cell can return to baseline. But at some point, you can cross that line, and we don't know exactly where it is, where we go into irreversible cell injury, which is really just the precursor to death. So here we have our healthy cell. This is our injured cell. And then here are depictions of the two types of cell death. This one is necrosis, and this is apoptosis. So you can see the difference in these. And I'm going to go through the cell injury and necrosis images in this video. And as I already mentioned, there's an apoptosis video that talks about that. Okay, so I do think it's worth spending a little time thinking about cell injury and how it causes disease, because ultimately, as future healthcare professionals, it's really critical for you to understand what causes the signs and symptoms of the patient in front of you. If you look at something, you look at a patient and you say, these are the signs and symptoms, therefore this is a diagnosis. The really excellent physician is going to say, okay, I know this is a diagnosis, and I understand that these are the pathologic processes that are providing these signs and symptoms, and these are the different injuries that can cause it. This is what's going to make you a truly great physician. So here are a variety of types of cell injury. We're going to cover these in each of the chapters of Robbins. So for each organ system, we'll be addressing abnormal immune reactions, genetic abnormalities, hypoxia and ischemia, infections. But this is just an introduction to the idea that these are what are the causes of disease, and that is referred to as the disease etiology. Now, these various stimuli are going to cause biochemical and structural changes. And this is the pathogenesis, how these biochemical and structural changes cause the abnormalities in cells and tissues, things that we can see at the molecular, functional, or morphologic level that are going to result in the clinical manifestations, the signs and symptoms of disease. And if you really understand the pathophysiology, you'll be able to follow this pathway backwards, and you'll be able to predict following this pathway forwards. So that is what I wish for all of you. So let's go into a little bit more detail on the causes of cell injury. So hypoxia and ischemia are both due to defects in oxygen delivery. In hypoxia, you have continued blood flow. So even though perhaps the oxygen tension is low, you're able to remove the metabolites of anaerobic metabolism. In ischemia, by contrast, you get blockage of the blood flow. So in addition to losing oxygen for downstream tissues, you also are allowing metabolites to build up, such as lactic acid. Now, both hypoxemia and ischemia have as their central defect ATP depletion, because you can no longer do oxidative phosphorylation because you have no oxygen. When you deplete ATP, your ion pumps are going to fail. This is important for maintaining cellular osmolarity. So in particular, that sodium-potassium ATPase that is typically pumping sodium out, potassium in. When we lose this, intracellular sodium builds up, potassium flows out, and we get then an osmotic gradient bringing in water, cell swelling. Also, as we shift, as I mentioned, to anaerobic metabolism, we're going to get a decrease in intracellular pH as lactic acid is produced. And this is going to have an impact on a lot of different factors, including enzyme enzyme activity, and it will also cause a decrease in protein synthesis. So I think it's pretty obvious how hypoxia and ischemia cause cell injury. Toxins can form free radicals, which are also covered in this chapter of Robbins. And these free radicals, highly reactive species, can attack the lipids in membranes, causing lipid peroxidation. This membrane damage is obviously very injurious to the cell. Toxins can also bind directly to proteins and have an impact on their function. Infectious agents can directly cause cell death. They may elaborate toxins or produce enzymes that cause injury, and they're going to stimulate an immune response. Now, the immune system is there to protect us, but there can be a lot of collateral damage, particularly in the setting of chronic infection, for example, in tuberculosis. Abnormal immunologic reactions we discuss in Chapter 5 of Robbins and Kumar Basic Pathology. This is hypersensitivity and autoimmunity. And these, particularly autoimmunity, is something that we'll be seeing in each organ system throughout the book. Genetic abnormalities, so mutations, can result in enzymes that don't function. So we see that, for example, in the lysosomal storage diseases in Chapter 4. Also, we can get misfolded proteins, where these proteins will accumulate. That's something we'll be focusing on in the central nervous system, particularly when we talk about the neurodegenerative diseases. Nutritional imbalances, so insufficient vitamins and nutrients, either insufficient nutrients or excess nutrients can cause cell injury. Vitamins, for example, if you have deficient vitamin B12 or folate, this can lead to megaloblastic anemia. And then physical agents, very simple: trauma, temperature extremes, radiation. These can cause direct cell injury. So this is an overview of what we're talking about in this chapter of Robbins. This is the healthy cell sitting here in homeostasis, some sort of injurious stimulus. If it's removed, we can move from reversible injury back to homeostasis, or if it's severe and progressive, we move on to irreversible injury. Now, we don't need to pass through reversible injury to get to irreversible injury. You can go directly here. That's another possibility. And it will take us from irreversible injury to cell death, either necrosis or apoptosis. So we'll be focusing on necrosis here. All right, I'm going to go through this figure in greater detail. I just wanted to show you the whole image. This comes from Robbins and Kumar Basic Pathology 11th edition. So we'll be working through the healthy cell, the injured cell, and then on to necrosis. So let's talk about reversible cell injury. So as I mentioned, that cell's going to recover if you remove that damaging stimulus. So that's the definition of reversible cell injury. So for example, if you are able to address the patient's hypertension, those cells that have begun to undergo hypertrophy to address this can actually remodel back to their normal size. What we see in reversible cell injury, the findings that we see at the morphologic level, are due primarily to a variety of different processes related to the failure of the energy-dependent ion pumps, which I already mentioned will lead to cell and organelle swelling. We can also see vacuolar degeneration or hydropic change, which is due to distended and pinched off segments of endoplasmic reticulum. And then another finding we see, particularly in organs and tissues that do a lot of lipid metabolism, is fatty change. An example, again, of how this is reversible: if someone drinks a large amount of alcohol over a short period of time, and if you were to look at a liver biopsy, you would actually see tiny droplets of fat in that liver cell. But if then several weeks later, after abstinence, you go back and you do another liver biopsy, that hepatocyte is going to look perfectly normal. It will have metabolized that fat. Now, what we'll see when we talk about when we talk about alcohol-related fatty liver disease, if you do not reverse that injury, if it is ongoing, you can go all the way on to cirrhosis. There are a number of findings that we see through electron microscopy, and that's because reversible cell injury is very subtle. There aren't a lot of changes because the cell hasn't in some ways changed all that much. It's still hoping it's going to be able to move back to its homeostatic self. However, this does tell us a little bit about what's going on in injury. So the plasma membrane will be affected. It can bleb, so little bubbles come off of it. You can get blunting of microvilli on cells. And loosening of the intercellular attachments. And if you get progressive, they can actually shed away. The mitochondria will swell, and we'll see these phospholipid amorphous densities due to damage to those membranes. The endoplasmic reticulum can dilate with detachment of ribosomes and dissociation of polysomes. The chromatin will lose its typical structure, it will begin to clump, and will have damaged cell membranes, and little bits of that, that lipid will form what we call, the phospholipids can form something that looks like myelin, so they're referred to as myelin figures. So let's take a look at a figure, which I think is much, much better than just words. Here we have our healthy cell. We have our nucleus, we have our endoplasmic reticulum. The little red dots here are the ribosomes. When we have that reversible injury, we're going to get swelling of the cell, so it's increasing in size. We're going to get swelling of our endoplasmic reticulum and our mitochondria, again due to decreased function of our sodium-potassium ATPases. We're going to see some chromatin clumping. Then on the ultrastructural level, we'll be able to appreciate some small amorphous deposits in the mitochondria, myelin figures. We can sometimes see these, this is almost vacuolated appearance of the cell due to these intracytoplasmic vacuoles, and then obviously through ultrastructural examination, detachment of ribosomes from the endoplasmic reticulum. So that's all well and good, but as I mentioned, if the stimulus continues or if it becomes worse, then we'll go into irreversible cell injury. So even after you remove that stimulus, the cell is on the fast track towards death. And we use the term irreversible cell injury. There's really just this slight shift to go from irreversible cell injury right on into death. And what this is characterized by, the reason it's irreversible, is because you have really three things that happen that say the cell can't save itself. So one is the inability to restore mitochondrial function. So this can be because the membranes are so damaged. And when you lose your mitochondria, you lose oxidative phosphorylation and ATP generation. If you get the altered structure and loss of function of membranes, so again, the plasma intracellular membranes, once they become damaged, you can get lysosomal digestion of the cell as our lysosomes come apart. And of course, DNA integrity is important for the cell to function. If you lose that structural integrity of our DNA and our chromatin, that is going to be absolutely insurmountable. And that's going to take us to, you can really go through a couple of different pathways, but this is really taking us to necrosis. And I'm going to focus on necrosis now. So what characterizes necrosis? The cellular membranes fall apart, the cellular enzymes leak, we get cellular digestion, and then inflammation comes in. So it's a very messy, gooey process, in contrast to apoptosis. Again, different video. So here we have our necrosis, we have our breakdown of our plasma membrane, our organelles, nucleus. With the breaking down of our plasma membrane, we're going to get leakage of contents, and this is what's going to cause that host reaction. And then ultrastructurally, we can see these larger deposits in the mitochondria. Again, not something typically useful to the practicing clinician. So what do we see in necrosis? And I'm going to tie it back to what causes it. So when you have that decreased pH, we're going to get an increase in our amount of denatured proteins. And denatured proteins are going to bind very tightly to our dye that we use, eosin, which is red. So that's going to make the cell look a little bit more red or eosinophilic. We also are going to have digestion of RNA as well as DNA by endonucleases. And RNA and DNA tend to bind hematoxylin, which is blue. So you increase your red, you decrease your blue, the cells look very reddish or eosinophilic. Now there's some nuclear processes as well that we can see. I'm tying this here because we just talked about decreased RNA. We can get decreased DNA, as I mentioned, and this makes the nucleus actually just disappear, karyolysis. It just dissolves away, it becomes very faint, and you don't see it. You can see this occasionally just on its own. It often will follow pycnosis and karyarexis. So in pycnosis, what happens is the nucleus shrinks down, and then it's going to look much more basophilic. Why is that? It's because the DNA that is still there is not spread out. So if you take something that fills this much and you clump it down like that, it's going to look a lot darker. What happens next is that pycnotic nucleus will become fragmented, and that's called karyarexis. And then following that, you can also get karyolysis of those bits of debris. So let's look at some histology to see if we can put this all together. So these are renal tubular cells, very happy and healthy. You can see their little brush border here, happy cells. If we give them early ischemic injury, so we decrease the blood flow and thereby the oxygen to these cells, you're going to see now that instead of that nice border, it's become roughened. So we have blebbing here of that plasma membrane. We have loosening of our cellular connections. You can see a little bit of space here between these cells. And look, here we have some eosinophilia. So some redder cells compared to the others. They're also swollen and enlarged due to loss of that osmotic gradient. However, if we were to restore flow, we would look right back like this once the cell is able to repair itself. If we do not, we're going to move on to necrosis, and this shows us again those features, these swollen cells that are now detaching. So they've moved from just being loose to detaching from the basement membrane. We see some pycnosis here. Look how dark these nuclei are. They're a little bit smaller. And we don't see karyorrhexis in this. I associate karyorrhexis primarily with rapid tumor growth as well as in hematopoietic cells, for example, neutrophils, once they are ready to die after doing their job and they undergo apoptosis, they will undergo karyorrhexis. We don't see karyorrhexis here, but we do see some basolysis. See this very pale nucleus right here? Here you can't even see the nucleus. And then just as an aside, I'll talk about this in a moment when I compare apoptosis and necrosis. So when we see here we have our karyolysis where this the DNA has been dissolved, let's look at this on a gel. It gives us a nice intro to a compare and contrast of apoptosis and necrosis. Now this is a viable cell, a happy, healthy cell, and in that the DNA is long, and then when you extract it, it becomes all clumped up into a big gluey mess. So when you run gel electrophoresis and it's being run through an electrical charge, it's all clumped together, it stays at the top of your gel. If you do apoptotic cells and extract their DNA, remember, or if you'll see in the video, you tend to have this very orderly destruction of the DNA by endonucleases in histone-associated bodies. And what we see here then is going to be a nice, neat programmed cell death. What we see here in necrosis is that we have that big glom of DNA and then just endonucleases are just randomly chopping it. So you end up with this smear. So let's compare and contrast necrosis and apoptosis. Once more, you'll find this is more useful when you look at the apoptosis video. In necrosis, we're going to have the enlarged cells, which we saw, the pycnosis, karyorrhexis, and karyolysis, the plasma membrane blown apart and disrupted, enzymatic digestion of the cellular contents that can leak out, causing an inflammatory response. And necrosis is invariably pathologic. You never get necrosis as part of a normal physiologic response. So it's typically, as I mentioned, the culmination of irreversible cell injury. Now, by contrast, what we see in apoptosis is shrinking of the cell, fragmentation into nucleosome-sized fragments, and what you will see when you look at the light microscopy is we'll go through pycnosis and karyorrhexis in apoptosis as well. Our membranes and our cellular contents will be intact, and we will not get inflammation. And apoptosis is often physiologic, although it can be pathologic. All right, so that brings us to the end of the discussion of the cellular processes of necrosis and cell injury. Let's now focus on the patterns of necrosis, as morphologic patterns. And there are 6, and I'm going to go through each of these in detail, beginning with coagulative necrosis. So coagulative necrosis is typically going to be secondary to ischemia, and as I say down here at the bottom, usually associated with infarcts in solid organs. When you have this ischemia or this infarct, what's going to happen is a clot is going to lodge in an end artery, say in the kidney or the spleen, prevent blood flow downstream. And the cells that are downstream are going to move into anaerobic metabolism, which is going to decrease pH. And when this happens, when it goes on long enough, we're going to get denaturation of our structural proteins and our enzymes. Now, this is critical, the loss of the enzyme function, because this means we're not going to digest that tissue very quickly. So the tissue architecture will be preserved. Also, if you think about it, that clot, which prevents blood flow, is also preventing blood flow, which is going to bring in our leukocytes, whose job it is to deal with dead cells. So we don't get recruited leukocytes coming in to digest these dead cells. Again, this is why we can get these the tissue architecture preserved and these eosinophilic anucleate cells persisting for days to weeks. It takes a long time for the leukocytes to make their way there. And because we don't have digestion, coagulative necrosis has a firm texture. Over time, however, recruited leukocytes will come along, they'll digest the dead cells, phagocytes will come in, remove the cellular debris, and things will be cleaned up, sometimes leaving a scar. And coagulative necrosis is what we see, as I mentioned, in infarcts in solid organs, so kidney, spleen. However, we don't see that in the brain, and I'll talk about that when we discuss liquefactive necrosis. So let's take a look at an image of a growth of a kidney that has coagulative necrosis. So you can see here we have our renal cortex, and here's the medulla. And here is our wedge-shaped infarct. Now, as you recall, the kidney has end arteries, and what we have here is the arteries coming here. Boom, this is where that thrombus is, because everything downstream is dead, and it's in this wedge shape because that's the tissue that is perfused by that artery. Now, it has this white tan appearance because there's no blood flow into it. This is in contrast to a hemorrhagic infarct, which we'll be talking about in other parts of Robbins. This is firm, it's almost a little bit raised from the surrounding tissue because there's been no digestion. And let's take a look at what we see histologically. This is just a beautiful images for compare and contrast. This is a viable kidney. So we can see a glomerulus, you see your renal tubules, and contrast that, please, with this coagulative necrosis. So you can see we've lost all of our nuclei. They've disappeared. It's perhaps a little bit more eosinophilic than the tubular cells that we see here. And then notice this inflammatory infiltrate, all these little blue cells percolating through. They're coming in slowly from this viable tissue in order to digest these. Now, there's a particular type of coagulative necrosis that we call gangrenous necrosis. It's not an official term, but it's used so commonly in clinical practice, it's useful to know. And what we see here is coagulative necrosis due to compromised perfusion, and it involves multiple tissue layers. So when we think about coagulative necrosis of the kidney, it's just doing that particular tissue. When we talk about it in the context of gangrene, what we're seeing, for example, in the lower extremity, is that we'll have necrosis of the skin, the subcutaneous tissue, muscle, blood vessels, nerve. So there's just a very thickened area of necrosis. Now, the classic association will be with the lower extremity in diabetes. In diabetes, you get peripheral vascular disease. So due to atherosclerosis, you get narrowing, less and less oxygen to those tissues, but it's a slow process. And I'll show you an example of a clinical specimen of diabetes. Now, this typically, it's almost mummified because it's a slow process and you don't get immune cells going in because of the vascular compromise. So it's this mummified dry tissue. However, if you get a superimposed bacterial infection, then you can get wet gangrene due to the immune response there. And as the bacteria dissolve the tissue. So this is an example of an amputation for gangrenous necrosis. Very helpful arrow in case you can't immediately pick up that this is the area of gangrene here, where you can see it has got this mummified, darkened tissue. Patient here is not feeling pain. If you were to cut here, they wouldn't feel that. Because the nerves are also are dead here as well. And so here is that interface. And if you cut through that, you would see dead skin, subcutaneous tissue, etc. So this brings us to, we've talked about coagulative necrosis and said it's usually associated with an infarct. Let's now talk about liquefactive necrosis, which is also related to infarcts, specifically in the central nervous system. So liquefactive necrosis can be seen with focal bacterial or fungal infections because as inflammatory cells rush into that tissue and attack the microbes, they're going to liquefy that tissue. And this sort of gooey mess of dead inflammatory cells and liquefied tissue is pus. And if you have a localized collection, it's referred to as an abscess. Now, we also will get, even though we see it in bacterial and fungal infections, we don't really think of it so much as liquefactive necrosis, except sometimes, for example, necrotizing fasciitis is very liquefactive. We really associate liquefactive necrosis with ischemic necrosis in the central nervous system. And this you can see following an infarct. So why do we see an infarct in the brain leading to liquefactive necrosis, but coagulative necrosis elsewhere? Well, if you think about the brain, it doesn't have a lot of structure to it. It's very soft, and there isn't a lot of tissue architecture to hold it together. So as you get this infarct-related changes, you're going to get liquefaction. And in it, the dead cells will be completely digested, forming this viscous liquid that is removed by phagocytes. So here is a gross image of a brain infarct. This is the infarct here. If you were to touch this with a gloved hand, it would feel soft, spongy, maybe even a little bit slimy. I'm not going to show you a histologic image because it basically just shows very little because the cells have been dissolved by inflammatory response. This brings us on to caseous necrosis. So caseous necrosis is associated with tuberculosis. So when you see caseous necrosis, you should immediately start thinking tuberculosis. Grossly, it's characterized by friable yellow-white necrotic tissue. And I'll show you an image of this. It looks cheese-like, so that's why they use the term caseous. Microscopically, we're going to see obliteration not only of the tissue architecture, but also the cellular outlines. And this is going to result in this granular amorphous pink cellular debris. Now, this is classically rimmed by macrophages and other inflammatory cells, and that construct is called a granuloma. And granulomas are something you'll be encountering throughout the different organ systems. So here you can see a section of lung from a patient with tuberculosis. Here is the lesion. And you can see if you were to pass a gloved hand over this, little bits of this tan white tissue would flake off. It just crumble off. And then you can also see here there's a little bit of fibrosis walling off this lesion from the rest of the lung. So here is a histologic image, and you can see here this is just pink granular debris. I'm not going to show you a higher power image because there's really nothing to see. It just all looks like just pink dust. You don't see cells there anymore. Here is the edge of that lesion. I'm going to go on higher power. So you can appreciate here this little granuloma. We have a multinucleated giant cell here. This is a gathering of epithelioid macrophages. And this wall here is also, this is some fibrosis around walling off that area of caseous necrosis. Now, let's talk about something that I find particularly interesting, which is fat necrosis. So this is a focal area of fat destruction, and what we think about when we see fat necrosis classically is going to be associated with acute pancreatitis. And we see this because pancreatic lipases are in an active form. When there's damage to the pancreas, those lipases are released, and there's this lovely overhanging piece of omentum right there, very fatty tissue. There's fat around the pancreas, and those lipases can start digesting the fat. You can also see fat necrosis due to trauma. So, for example, if a patient has blunt trauma to a fatty part of the body, they may form fat necrosis there. Now, grossly, they're going to be these chalky white areas that are firm and a little chalky. They actually feel like chalk when you touch them. Microscopically, we'll see the outlines of these necrotic fat cells, as well as we'll get some calcium deposition, because when you have these fats being released, they're going to combine with calcium in a process called saponification, and calcium will there be drawn from bodily fluids and deposit in the fat. We'll also be seeing, of course, some inflammation. So here is a section of omentum from a patient with acute pancreatitis. Here you can see quite clearly those chalky white deposits. Really quite clear, very obvious. Okay, now microscopically, this is not the best image. I'm going to show you a better image in a moment, but because this one shows some pancreas in this individual with acute pancreatitis, I'm going to show this. Here is the fat necrosis, where you can see these eosinophilic fat cells. There's some more fat necrosis here, not quite as prominent. Would have to look on higher magnification. Some of this may still be viable. And you can see here this inflammatory infiltrate. Now here's a much better view which compares and contrasts fat necrosis to viable fat. Here you can see we have this gray material, this granular gray material depositing. This is early calcium deposition. We've lost the delicate membranes between the cells. These are the viable fat cells here, a little nucleus, another nucleus here, happy viable fat, dead fat with calcium deposition. And here we have some additional inflammatory response. This is one more image. One thing I wanted to point out is when you have fat necrosis, there's a lot of lipid being released. Here will come the macrophages to gobble that up. So these are what are classically referred to as foamy macrophages. And here again is a nidus of calcification. Here's another that's sort of been chunked out a little bit in the sectioning. Okay, the last one that we'll talk about is fibrinoid necrosis, which is a very particular type of necrosis that we associate with autoimmune disease, particularly in the vessels. And in this we get immune complexes, so antigen-antibody complexes, as well as serum protein, which deposits in the arterial walls, causing vascular damage. There's nothing to see grossly, but on microscopy you'll see this brightly eosinophilic amorphous material that looks like fibrin, hence we call it fibrinoid. And this is the classic example. This is probably the most closely associated with fibrinoid necrosis. This is polyarteritis nodosa. You can see here is the fibrinoid necrosis part. This is this bright pink material because remember, denatured proteins are going to be more eosinophilic because they glob onto eosin. And so you see this here in the vessel wall. It looks a little bit like fibrin, probably a little bit brighter pink. All right, so this brings us to our penultimate slide, looking at the questions, asking you to read these and then see if you can answer them. And if not, go back and watch the video again. As always, thank you very much for your time and attention. Please follow me on Twitter. Put comments down below. Let me know what helps and what I can do to make this better for you. So thank you very much.